Okay, welcome everybody. Welcome to the ICMDA webinar series brought to you from the International Christian Medical and Dental Association, an organisation of more than 60,000 Christian doctors and dentists representing more than 100 countries around the world. The observant among you will have noticed that I'm not Dr. Peter Saunders, who is away this week in Central Africa. My name is David Randall. I'm a consultant nephrologist working at the Royal London Hospital in East London. And I'll be presenting today's session. I'm delighted to be joined today by Ewan Goligher, who is a critical care doctor from Canada, and he'll be speaking to us in a few moments with a Christian take on assisted suicide and euthanasia. Anyway, it's a pleasure to introduce Dr. Ewan Goligher. Ewan is an assistant professor of medicine at the University of British Columbia, and he's a practicing clinician specialising in critical care medicine. Ewan, we're very grateful that you can join us today, and we look forward to hearing what you have to say. Thank you.
Thank you very much, David, for the introduction, and grateful for the opportunity to be presenting at this seminar. It's a privilege to be here and to speak to you all about an issue that I think is weighty and pressing for so many of us who are in healthcare. I am a Canadian physician. I've been involved in addressing this issue for about a decade, since it was first being entertained publicly in Canada. And so I'm pleased to have the opportunity to speak to you about a Christian response to assisted death, which is something that I've been reflecting on over quite a number of years now. First off, when we speak about this issue, I think it's very important to be crystal clear about what we're talking about. And the issue of distinction and definition is critical. So when we talk about assisted death, there's a number of related terms: euthanasia, assisted suicide, medical aid in dying. Really what we're talking about collectively are deliberate actions on the part of the doctor, or sometimes on the part of the nurse, to deliberately cause death in the name of practicing medicine. And this really is what defines or sets apart this set of practices. Euthanasia, of course, is where the lethal drugs are directly administered by the physician. Assisted suicide is where the lethal drugs are prescribed, but then self-ingested by the patient. So there's a slight distinction in how it's operationalized, but really at the end of the day, morally, they're the same thing: a deliberate action on the part of the physician to deliberately cause the patient's death. And sometimes this is referred to as physician-assisted death, sometimes more euphemistically as medical aid in dying. And that's really what we're talking about. What we're not talking about today are issues like withholding or withdrawing life-sustaining measures, palliative care, even terminal sedation, or a decision to decline heroic interventions. Those are not actions aimed at deliberately causing death. And so we're really not talking about them. Those are not related to euthanasia. And I think it's very important to make that distinction, because when we're critiquing the practice of euthanasia, we want to make clear that we're strongly supportive of palliative care and of appropriate limitations on heroic interventions that sometimes are proposed for patients. So the practice of euthanasia has been quite a story in Canada over the last decade. And while it's been legalized in other jurisdictions, such as the Netherlands or Belgium, or certain jurisdictions, the United States, and more recently in Australia, and a few other countries, it's really grown very dramatically in Canada since it was first legalized about 10 years ago. So shortly after I finished my clinical training in 2012, there began to be a lot of public interest and discussion about this issue. It was precipitated by a couple of specific cases that were in the media and in the courts. And there was a tremendous kind of push from the media and from different quarters of society to promote this practice. So I recalled very distinctly in the fall of 2014 being at a medical conference here in Toronto, where a speaker got up and publicly advocated for the practice, which was the first time that ever really had happened. And of course, it represents a massive sea change in medical ethics, whereas deliberately causing a patient's death was utterly taboo in the practice of medicine. That was really the time when there was a complete 180 degree, and this became something that was highly lauded and praised and seen as a virtuous thing to be involved in. So in 2015, In Canada, the Supreme Court struck down the criminal prohibition on the practice and gave the federal government a year to craft legislation to legalize it. And in 2016, that legislation came down and originally restricted euthanasia to being available only to those for whom death was reasonably foreseeable. But then in 2021, the legislation was expanded to allow euthanasia for persons with a disability and grievous and irremediable suffering for whom death was not reasonably foreseeable. So now we're starting to talk about ending the lives of people who were otherwise not expected to die. And you can see the way the practice has grown dramatically in Canada over time. The first year was legal, about 1,000 patients died by euthanasia, and in 2022, just over 13,000, a small proportion of whom actually were not dying, but rather sought death because of their disabilities. Now, the case for euthanasia is probably something that many of us have encountered. It's said to be patient-centered. It's said to empower patients to respect their autonomy. It's said to be about their right to self-determination at the end of life, granting them the kind of control over their life and their suffering that they ought to have. It's said to be about freedom from suffering and compassion. And in particular, the attitude that I encountered as a physician, talking with colleagues, talking with others broadly in society, was that basically the question is, why not do this? What's wrong with this? What possible reason could we give to say that this is not, if this is what the patient wants? And a good summary of the case, a very short summary, was published by a colleague of mine in critical care medicine, James Downer, basically summarizing the case as care, compassion, and respect. And when you put it that way, it really is a powerful language that feels morally compelling. And so this really became widely embraced. And very quickly, those of us who were going to be opposed to euthanasia were going to be A, in the minority, and B, seen as sort of not supportive of the patient's own best interests and supportive, respecting their autonomy. So this put us in a very difficult position. And this really developed shortly after I finished my clinical training. After I finished all my clinical training in internal medicine and critical care medicine, I pursued graduate training in respiratory physiology. I was pursuing a career as a clinician scientist. And in the midst of that very early stage of my career, this moral sea change occurred. And as many of the colleagues around me said that they would support this, that this was the right thing to do, that this was the patient's right, the weighty question became for the small minority of us who oppose this to say, how can we say no? How do we say no to this practice? And you may remember cases in the media, like the story of Brittany Maynard, who was an American woman with a terminal illness, a brain tumor, who traveled to Oregon to get assisted suicide because she wanted to die on her own terms. And this was a very powerful story in the media, and it was basically seen like, how can any doctor refuse to provide the kind of death that a patient like her wants? This was a very strong wave of moral enthusiasm that was a challenge to resist. And in particular, I became involved for a variety of reasons. First of all, working in the intensive care unit, I'm involved regularly in navigating end-of-life decision-making, and I anticipated that this may come up from time to time. It'd be something that my patients who are dying in the ICU might request. And so I need to think carefully about how I was going to navigate this, how I would, why I would oppose it, and how I would explain that opposition to my colleagues and to patients. Secondly, one of the powerful arguments that was made in support of euthanasia was the idea that it's basically equivalent to withholding or withdrawing life-sustaining measures. We're already deciding the timing and manner of somebody's death in the ICU all the time. So how is euthanasia really all that different? And so because I'm involved in withholding and withdrawing life-sustaining measures and often and generally think it's morally the right thing to be doing, I knew I was going to have to offer a justification for making the distinction between the two practices. And then thirdly, this really was forced on us in Ontario, Canada, as a crisis of conscience, because the College of Physicians that governs physician practice laid down a requirement for making an effective referral to a willing provider. So if I was to receive a request, I, was free to say no to honoring the request, but I was expected to actively send the patient to another physician who would end their life at their request. And because that really makes me morally complicit in the practice, that was not something I was willing to do. So how were we who opposed the practice going to push back against this effective referral requirement, which essentially put us at risk of disciplinary action? This was litigated in the courts twice, and the Christian Medical and Dental Association of Canada was part of that, a core part of that legal effort. And unfortunately, we lost both times. It was acknowledged that we had a charter right to freedom of conscience, but that was overruled by the patient's right to access healthcare. And so the question really became, how do we defend conscientious objection? How do we stand up to say that we have the right to say no to a patient about this? And so for all these reasons, I became very involved in thinking, writing about this, and weighing how to respond. Now, one of the central challenges to responding to this issue in the West, in Canada, and I imagine it's the same in the United Kingdom, many other countries, particularly in the West, is that the moral milieu in which we inhabit is characterized by pluralism and emotivism. So what do I mean by those terms? Well, pluralism is the idea that many competing worldviews should be accommodated and respected at the same time. And all are seen to be and ought to be treated as equally valid. No one view can be expected to be sort of superior or dominant over the others. And while that ought, on first glance, to promote a spirit of toleration towards those who object, really what happens is that you find yourself without really any real grounds to say why you think you're right and therefore somebody else is wrong. Every view needs to be respected equally, which means nobody's wrong, but also nobody's right. And so it's very difficult to defend a moral position when people have these multiple competing perspectives on what morality is and where it comes from, and all need to be equally accommodated and respected without any real effort to defend why one might be right and one might be wrong. Secondly, this idea of emotivism is an idea articulated by moral philosophers who describe the fact that in the modern contemporary West, largely the way that we make moral decisions is basically just how we feel about them. To make a moral claim is basically to express a form of feeling. And in fact, you generally often find people describing the moral beliefs in these terms: I feel this is right, I feel this is wrong. And when morality is reduced to mere feeling, to mere emotion, it becomes impossible to have a meaningful, rational debate about it. It's just something that people assert, and that's the end of the story. So a moral claim becomes a conversation stopper instead of a conversation starter. And so it's very difficult for us to respond with a strong moral position. And so how then do we find a moral authority to which we may appeal to defend our opposition to euthanasia? What kind of overarching moral standard can we leverage to explain to people why they should agree with us that this practice is wrong? Is there a common moral starting point? And one of the very early pieces that I wrote about this was the idea that really the widespread embrace of euthanasia was the consequence of a society that had embraced Nietzsche's concept that God was dead. As we call this kind of provocatively euthanizing God. And the fact that if you reject the existence of God and the authority of God, you lose that overarching moral standard. And that explains why all of a sudden something like this could become acceptable to people. And we argued that, of course, God was not dead, that there was very good reasons to believe that he was very much alive, and therefore was the final moral authority and the one to which we could appeal to justify our conscientious objection. So that was a very early attempt. The problem, of course, is that religious beliefs in this pluralistic concept, in this pluralistic context, are not really respected as a basis for moral decision-making. So one kind of eminent moral philosopher in Canada who wrote about assisted death puts it this way, that in a religiously pluralistic society, here's this problem of pluralism: public policy governing the conduct of all cannot be justified by reference to faith-based premises shared only by some. So if you're living in this quote-unquote secular environment You can't rely on your religious beliefs as a basis for conscientious objection. And in particular, what's striking is that there are some who discuss religious belief as a kind of competing interest in debates around medical ethics. So these authors in the BMJ wrote, Richard Smith and Jane Blasby write that religious belief should be declared as a competing interest. So if you, as a Christian, come to this to talk about this issue, they say you're intrinsically conflicted because you have this personal bias arising from your religious beliefs. And so the question is, how then do we respond? What is an effective and persuasive response to this issue look like in the face of these challenges to moral discussion? So I want to share my thoughts on this and the approach that I've come to after years and years of reading and reflection. And at the end, I'll mention the book that I recently published that describes this approach in a lot more detail. But I think the first thing to understand is that in God's common grace, there is a natural knowledge of moral truth that people have just by virtue of the fact that they're human beings made in the image of God. This is what's sometimes called what we can't not know. These are things that we know by nature. We have what the medievals called an unerring knowledge of the necessity of being good. So even moral philosophers like Peter Singer, who might be thought of as relativists at a certain level, will write about this fact that they can't explain exactly why they ought to be good, but they just know that they ought to be good. So somehow everyone has this fundamental concept that they ought to be good and they ought to do good. They all have a sense that we ought to be rational, just, and fair, and they all have a sense that people matter. And this observation that people seem to have some natural knowledge of morality is backed up by divine revelation in Scripture. So, for example, Paul in Romans chapter 2 argues that the Gentiles who do not have the law by nature do what the law requires. They are a law to themselves, even though they do not have the law. So they might not have Scripture, they might not have divine special revelation, or they might have it but not recognize its authority. But even so, just by nature, they show that the law is written on their hearts because they do by nature what the law requires. They are a law to themselves. And what's striking is that if you look at the case for euthanasia, you see this natural knowledge of right and wrong emerging. First of all, the people who advocate for euthanasia all say that it's a good thing to do. They want it to be a good thing to do. So they offer moral justifications for it. It's not something that they say, hey, it's bad, but we're going to do it anyways. No, they know that they need to show that it's good. And secondly, they try to show that it's good by casting it in terms of the value of people. They say it's patient-centered, it's empowering, it's about respect for autonomy. And insofar as these are all ways of respecting human value, the case for euthanasia is predicated on the idea that people matter. And so there is some natural knowledge of right and wrong and about the value of people that we can recognize and lean on as a common moral starting point. And the challenge becomes to show that the case for euthanasia is actually a distortion or a fallacious interpretation of what it means to respect the value of people. And that's what I want to briefly outline in the time that remains. So I have 3 points to make. That when it comes to a Christian response to assisted death, what we need to do is we need to, first of all, recognize the true value of the person, the true nature of their value. Secondly, we need to recognize the value of the body. And thirdly, we need to recognize the true issue, which is more of a spiritual issue rather than a medical problem. So first of all, recognizing the true value of the person. So when we say that people matter, what do we mean exactly? We can divide value into 2 basic categories. There's extrinsic value and intrinsic value. And extrinsic value is to say that someone or something matters because it's useful to you. So for example, my iPhone, incredibly valuable to me. I carry it everywhere I go. It's at my bedstead at night. I look at it when I wake up in the morning, probably pay more attention to it than I ought to. And if I lost it, I would be devastated because I rely on it so heavily. But if it was to stop working, it would lose all value immediately, and I would immediately replace it with a new one. So the value of my iPhone is not the value inherent in the thing itself. It's not intrinsic to the phone. It arises from its utility. Whereas, say, something like the Mona Lisa or a great work of art is an example of intrinsic value, something that we value for the sake of just what it is. It has value by nature. It's not useful. It hangs in a museum. People come to look at it because they value it, but it doesn't do anything for anybody. But they recognize that it has value by virtue of what it is, a great work of art that highlights the greatness of the artist. And if perhaps the paradigm example of intrinsic value in this world are people. People matter, and they matter not merely because they're useful to us, but rather because they matter simply by virtue of who and what they are. We recognize that because people are priceless and irreplaceable. You can't, when you lose a person, when somebody dies, you lose something that's priceless and irreplaceable. You can't just replace a person with someone else. And in fact, if you treat someone as if they only matter to you because they're useful to you, well, we actually call that demeaning and disvaluing to people, and we know that's wrong. We ought not to treat people merely as a means to an end. And so we recognize and we know by nature that people have intrinsic value. Now, if it's the case that people have intrinsic and inherent value, if they're priceless and irreplaceable, then it means that their existence is inherently good. Because to say that something is valuable is to say that it's good that it exists. So if something has intrinsic and unchanging and therefore unchanging value, then its existence has intrinsic and unchanging value. Now, when we go to euthanize someone, what the patient is saying to themselves when they ask for euthanasia is, my existence no longer matters. Therefore, it's okay to end it. There's no value in my existence. Therefore, it can be ended. And when the doctor goes to euthanize the patient, they're saying, this person's existence no longer matters. In fact, it's good that they no longer exist. It's good for me to end them. But what that necessarily implies is that the person themselves has lost their value. And if they have lost their value, then they never had intrinsic and inherent value in the first place, because you cannot lose intrinsic value. So euthanasia treats people as if they have merely extrinsic value, not intrinsic value. And so that demonstrates the way in which euthanasia actually devalues people. Now, this came home to me in a very crystal clear way when I was testifying before the Senate of Canada about the expansion of this legislation in 2020. And I had the privilege of testifying next to two women who were representing the disability community. They were very intelligent and articulate women with very visible disabilities. And as they were testifying this, the proposal for the legislation was to expand euthanasia to allow people with disabilities to access euthanasia if they so chose. And they were protesting this and saying that it was put persons living with disabilities at risk of being ended against their wishes. So they were very concerned about the rights of the disability community. And what I realized is that as we were all testifying against this law, for me, this was a matter of professional concern. But if this legislation passed, I would not become eligible for assisted suicide or euthanasia, but they would. For them, this was a matter of life and death. And what I realized is, what does this say about the value of each of us in the eyes of society? My life would still be protected. Causing my death would still be wrong, but they would become disposable or dispensable. And so their lives would no longer be absolutely protected. So what does this say about our relative value in the eyes of society? You can't call into question the value of someone's existence without calling into question the value of the person themselves. And ultimately, this is the deep problem with euthanasia. It is that's profoundly demeaning to human value. Now, people try to respond to this by saying, well, it's about autonomy. And if somebody says that their existence matters, then we can respect the value of their existence, but we need to respect their autonomy. So really what we're saying is the value of the person's life depends on the value of the person themselves. The only source of real human value then would be self-affirmation. But this is an unbearable weight for us to bear because we as humans are too weak and too frail and fragile to actually be able to sustain a deep sense of our own value. We need to be valued by others in order to see our own value. We're dependent on others. And consequently, the idea of value from autonomy puts us all at risk because we're all inclined to doubt our own value. We're all struggle to affirm our own value and significance. And it's when other people see and recognize our true intrinsic value and show it to us by the words they say to us, and by the way they treat us, that we begin to see our own value more clearly. And so we're dependent on others. An autonomy-based foundation for value simply will not sustain true human value. Now, secondly, we need to recognize the value of the body. When euthanasia is performed, it's an assault on the body. So the procedure to cause someone's death in Canada is something typically like the following. First, midazolam 10 milligrams is administered to put the patient into a deep sleep or render them unconscious. Then propofol, an intravenous anesthetic, is administered in a massive dose. So they give a gram of propofol. The intention there is to basically shut off the brain, including the basic brainstem respiratory centers, and that all by itself would generally be lethal. Then they administer a very large dose of rocuronium to paralyze the breathing muscles. Then lidocaine is administered and bupivacaine is administered a large dose to cause cardiac arrest. So progressively, we're assaulting the brain, the respiratory muscles, and the heart to bring about death. Now, this is said to be an act that does good for the patient, but notice the fact that it does no good for the body. So we're doing good for the patient by fundamentally destroying the body. And what we're seeing here is the way in which morally we've separated the patient from their body. We treat the patient as if there's something separate from their body, essentially denying that they're an embodied creature. And in so doing, we basically say the body doesn't really matter. You can do with it whatever you want, which is a profound something for a profession that's dedicated itself to the good of the body to now turn around and say we can destroy the body to do good for the patient. And so really what we're seeing is a fundamental philosophy or kind of quasi-religious belief system that views people as disembodied. It's an anthropology of disembodiment. And multiple philosophers have noted this. So Robert George describes this as a resurgent Gnosticism, treating the body as a mere extrinsic tool. The father of modern bioethics, Paul Ramsey, who was a Christian theologian at Princeton, observed the death of the bond of soul with body in the understanding of personal life in a dualistic age. So this is writing in the 60s and 70s. This is very early, and now we're really seeing this come to fruition. And the philosopher Alistair MacIntyre talks about the way in which we're forgetting the body, and literally euthanasia completely forgets the body. I think that then we should understand that this is fundamentally an act of desecration, because people are bodies. As Christians, we recognize this, but even materialists, atheists, secularists need to recognize people are bodies, because if they're not bodies, then what are they? Now, of course, as Christians, we recognize people are bodies and souls, and we want to affirm both the existence of the soul and the body. But they're not only a soul, they are fundamentally embodied creatures created from the dust of the ground. So people are bodies, and if people matter, then bodies matter. So really what we're doing here when we're destroying the body is performing a fundamental act of desecration. And Matthew Lee Anderson observes that suicide is incoherent because it severs a person from the basis for that individual's very self. Without the body, you're not a human. But because you have a body, it comes to you as a gift. It's what makes you human. And so the failure to treat the body with respect as something sacred is profoundly demeaning again to the human person. And so that's why this is wrong. Now, additionally, we need to recognize the way that euthanasia is an act of blind faith. There is a fundamental kind of blind faith involved in performing euthanasia. And how does this work? Well, essentially the logic of euthanasia is that you decide whether or not you're better off dead than alive. And if you decide as a rational creature that you're better off dead than alive, then you're warranted in having your life ended. This is the fundamental logic. And if you read the philosophical work, you'll see this is exactly the way the case for euthanasia is outlined, is that it's a decision that you make as an autonomous and rational creature about whether death is beneficial for you. Now, the way that decision is made in the literature is that you weigh up the goods of being alive and the harms of being alive. And if the harms of being alive outweigh the goods, well, then it seems like you'd be better off dead. And so there's a kind of rational calculus, what I'm calling here the death calculus, to decide whether you should end yourself. But what's massively missing from this death calculus and from any discussion in the literature is the question of what it's like to be dead. Because the question of whether you're better off dead than alive depends not only on what it's like to be alive, but also what it's like to be dead. But nobody talks about this. And this, you see, is where a fundamental, deep assumption implicit in the practice is being made about what it's like to be dead, that death is either nothingness or some kind of paradise or reincarnation. But of course, nobody makes any effort to justify that belief. It's just implicit in the practice and utterly unjustified and unproven. There's no class in medical school that tells you what the afterlife is like. And of course, this issue is one of the reasons why we ought to be very hesitant to cause death, because we don't know what comes after. Speaking at least from the standpoint of a human relying on pure sense experience, this was powerfully articulated by Shakespeare, of all places, in Hamlet, where in Hamlet's famous soliloquy, To Be or Not to Be, he talks about the way in which the uncertainty of death prevents us from taking our own lives. So here he writes, to sleep, perchance to dream. Aye, there's the rub. For in that sleep of death, what dreams may come when we have shuffled off this mortal coil must give us pause. There's the respect that makes calamity of so long life. Who would fardels bear to grunt and sweat under a weary life, but that the dread of something after death, the undiscovered country from whose bourne no traveler returns, puzzles the will and makes us rather bear those ills we have than fly to those we know not of. Thus conscience doth make cowards of us all. These are famous words. But what you note here is Hamlet's being very rational. He's saying, we don't know what it's like to be dead, so better to have the devil you know than the devil you don't, and wisely and rationally chooses not to end himself. So what we're seeing then is that this decision to use death as a treatment for suffering fundamentally constitutes a blind leap of faith. We don't know what it's like in that undiscovered country from whose bourne no traveler returns. So this is a medical intervention where the outcome is actually unknown, and we have no way of following up with the patient to find out what's happening to them. It's a kind of experimental intervention without any possible ability of measuring the outcome. Can you think of anything else in medicine where this would be acceptable? And clearly not. And so this shows that euthanasia is not rationally justifiable, even on the basis of its own logic. Now, very briefly, we need to recognize what is the real problem that drives the desire for death. What is it that motivates people to seek assisted death? These are profound existential issues. We cannot blow off these concerns as anything less than profoundly important concerns. In fact, the issues around euthanasia are some of the most fundamental questions that we wrestle with as human beings. And as all of us who work in healthcare know and are privileged to care for those who are suffering and those who are dying, the process of suffering and disability and death raises profound existential challenges for patients. So this sense that we're losing autonomy and control over our lives. We're not able to enjoy life the way that we once did. We're afraid of being a burden and dependent on others. And in particularly in our society where independence and personal freedom and autonomy are valued above other things, it's profoundly painful to lose these things. It's a sense that if I can't have what I want in life, then life is not worth living. It's intolerable. And what's really important to observe is that despite all the talk about euthanasia as compassion on physical suffering for people in agony, almost nobody who seeks euthanasia actually cites inadequate pain control or symptoms as the basis for their request. And this is well documented in the studies that report cohorts of patients seeking euthanasia by euthanasia advocates. Like this paper from my own hospital published in 2017 cites the fact that very few patients seek it for inadequate pain control. So really what we're facing here is the fundamental problem of finding meaning and purpose in the face of suffering. What is it that makes life worth living when we have to face grievous and irremediable suffering? This is a profound question, but it's a question that medicine doesn't have an answer to because it's a philosophical question. It's a spiritual question. It's not a medical question. And I think Albert Camus, in his Myth of Sisyphus, beautifully articulates the mindset that motivates the desire for euthanasia. He writes, dying voluntarily, that is by suicide, implies that you have recognized, even instinctively, the absence of any profound reason for living, the insane character of that daily agitation of bearing with suffering and trouble, and the uselessness of suffering. So this idea that suffering is useless, that there's no meaning and purpose behind it, motivates people to feel the sense of despair that says, you know what, there's no point in going on with life. I just want to get it over. And somehow getting euthanasia, getting death on your terms at your time becomes a way of having one last fleeting grasp of autonomy and control before your existence is obliterated. And so from that sense, this is a powerful intervention for a spiritual problem, not for a medical problem. And we're facing here fundamental questions about how we find meaning and purpose in the face of suffering. And so this, of course, as Christians, we know is a question that can only ultimately be answered by an appeal to the good news that Jesus Christ, the Son of God, was incarnated in the flesh, lived, died, and was resurrected alive, ascended to heaven, and will return bodily to give us, those who trust in him, eternal life. And the deep sense that God is the maker of all things, that God is sovereign over all things, that his purposes are at work in the world so that we can be absolutely confident that even when he calls us to suffer, there is good underneath it at work, that one day this light and momentary affliction will be shown to be utterly incomparable to the weight of glory that awaits us. That is the ultimate answer to the problem of suffering. The gospel teaches us the true value that people have made in God's image, creatures made in God's image and likeness, to know him, to worship him, and to see him, and to glorify him, and to value him, and to see their own value, and to exercise kingly rule over the created world to expand God's kingdom. We see the true value of the body. The Son of God, the second person of the Trinity, became flesh and dwelt among us. What could possibly highlight the significance of the human body and the sacredness of the body in our eyes than the fact that God became man? We also know as Christians the true knowledge of what lies beyond the grave. We need not fear death because we know that if we trust in Christ, he has purchased for us eternal life bodily with him forever, and we'll be free from suffering. We also know that death brings very serious and sobering consequences of the reality that we must all appear before the judgment seat of God. So it's not something to be taken lightly. We will all be called to account for how we've lived our lives, and ending someone is therefore a very serious and sobering thing to do. And I believe the gospel gives us the resources to suffer because it helps us to see and have confidence in the purposes of God, gives us hope in the promises of God for this life and the life to come, and also invites us to enjoy the love of God's presence. Because we might be called to suffer in this life, but there's the one thing that suffering can never take from us, which is the reality that Jesus Christ, the Son of God, who loved us and gave himself for us, is with us, will never leave us nor forsake us. We're indwelt by his Holy Spirit, and we enjoy communion with God. And in fact, suffering becomes an opportunity to show his value and worth by trusting patiently in him in a way that we would never have if we weren't called to suffer. So suffering then becomes something profoundly meaningful and of deep purpose. The gospel gives us a place of belonging. We become part of the body of Christ, and it's the church ultimately that provides us with the community that we need to see our value and to feel our value and to care for us in the dying process. The church is what people need. So to summarize, a Christian response to this issue begins by recognizing the true nature of human value, that it's intrinsic and extrinsic, and that euthanasia denies that people have intrinsic value. It recognizes the true value of the human body, that the human body is sacred and something to be treated with profound respect. We recognize that euthanasia is actually a kind of quasi-religious ideology based on blind faith in what it's like to be dead, not rationally justified. And we recognize that ultimately this is really about the problem of suffering and finding meaning in life. And in our cultural moment, the West faces a profound nihilism where people have given up on the idea that life could have true and ultimate meaning. And so the good news of the gospel is that they do have meaning and they do have purpose, even when they suffer. And so we ultimately, our boast is in the cross as the true solution to suffering. And our calling as Christian healthcare workers, physicians, nurses, is to bear witness to the truth by opposing this practice standing up for human value by saying this is wrong, we will not participate, and by encouraging our churches to be places of refuge for those who are suffering, for those who are lonely, for those who are weak and in need, so that they never feel that they've lost their value. So with that, I just want to point you to a few resources. Recently, I published a couple of books on this issue, How Should We Then Die, which summarizes this Christian response to physician-assisted death. Also, with my pastor, I published a catechism on issues around death and dying. There's 70 questions and answers about ethical issues related to death and dying. And then I also do want to highlight the work of Professor John Wyatt, who I'm sure is no stranger to many at ICMDA, who wrote a very important book on the ethics of the right to die and how to respond to this in very practical terms. So thank you again for the privilege of presenting. I'll be happy to take questions and just share my email address there in case any of you want to get in touch with me. Thank you very much.
Thank you so much, Ewan, for a really fascinating and thought-provoking discussion. We're very grateful to you. I was particularly struck by a few of the things you said, the analogy perhaps to a smartphone. I've thought about this myself, how we like to think that we're the apps, we're the social media, and the hardware is not important. It's something we can chuck away. Also, that I was really compelled by that idea of seeking that shared understanding of what's good, and I thought that was very interesting and nice to hear how you were using that in thinking that through. I get to ask the first question because I'm hosting. I'm interested. Obviously, your colleagues, so your non-Christian colleagues, have come on a huge journey in terms of how they practice medicine. What's that been like for them? If you go back 10 years, no one was doing euthanasia, no one was doing assisted suicide. Has that been an easy transition for them? Have there been discussions in the department? Have people wrestled with this, or has it been a very kind of swift transition? Had the kind of intellectual movement already happened before this became legal? How's that played out in your department?
Really interesting question. When this first came out, it provoked some discussion. But I would say that perhaps one of the our Canadian society was very primed to receive this idea, the idea of personal autonomy, and that we were, the good that we do for patients is by empowering them and putting them in control. And already an idea that was widely embraced, and so the kind of preconditions for embracing this were really already pretty widely true in the attitudes of most physicians. So it was something that seemed intuitive and natural to people. And additionally, because of this emotivism, the fact that people have kind of given up thinking that you can be rational about morality, it's just sort of something you feel. There was no law to discuss because it just seemed sort of right to a lot of people. I would say what's important to recognize is actually there are very few physicians who are actually willing to perform euthanasia. Most are willing to make a referral, say, okay, I'm going to wash my hands of this, sort of like Pontius Pilate. But very few are willing to actually be the ones to perform the act. And there are physicians in Canada who perform literally hundreds of these procedures because so few are willing to do it. So you see this kind of interesting kind of hesitance to actually take it up. It's people say, well, it's socially accepted. Other people are willing to do it. It's what the patient wants. So fine, I won't stand in the way. But much more hesitant to actually make it part of their own practice. And so I think deep down, there's a kind of recognition there's something morally problematic about this, such that I don't want to get involved myself. So there's not much discussion anymore. It's really sort of just part of the water we're swimming in now. And in general, I would say that people have had a hard time discussing it because it was just seen to be a matter of rights, personal choice, and how do you respond to that? So this was part of the challenge that I took up writing the book, was how do we respond to that and have a real moral discussion?
Thank you very much. Kind of going on for that, there's been a few questions come up about how do you deal with this question of referring on? How do you handle that personally? The requirement to make an effective referral. Obviously, you talked about challenging that unsuccessfully in the courts. So given that's happened, how do you handle that? Is there a range of ways that different Christian doctors handle this, or any actively involved in the process? How's that played out in the Christian community?
Yeah, so I'm an intensive care physician and I work in the intensive care unit. So one of the things I decided early on was that it would be appropriate for me to allow the patient to be taken over by a different MRP or most responsible physician or attending physician who could then make a referral if they wanted to. So I wouldn't make the referral, but I'd allow someone else to take over their care, because when the patient's admitted to hospital, they don't get to pick whether I'm looking after them or not. And so basically, say this is me saying I'm going to get out of the way, but I'm not going to be complicit by making a referral myself. And some people think that that's sort of like, kind of morally slicing and dicing, but I think there's a justification. And in general, that's actually been the position articulated for kind of in-hospital handling of cases of conscience by multiple professional societies in other contexts. So I think it's reasonable and defensible. And fortunately, I have colleagues who are sufficiently respectful that they would be willing to take over the patient without requiring me to make a referral. And so that's how I'm managing it and how other colleagues are managing it. Hospitals run by religious organizations like Catholic hospitals are not permitting this on their premises. And so there's a bit of a refuge there, although that's actually being challenged in the courts. And so institutional freedom of conscience becomes a challenge. What's very important to know is that many family doctors, many Christians practicing palliative care have had to substantially cut back or change their practices in order to avoid being receiving these requests, because they're basically would be expected to make an effective referral in that context. And so in order to do that, some have retired early. Young trainees are trying to go into areas of medicine where they're unlikely to get these requests. So it's really changing the way that Christians are involved in medical care. I think much to the detriment of the good of patients in Canada, sadly.
Interesting. How do you have these conversations with secular colleagues? You talked about the kind of pluralism, the emotivism that, people are starting from quite a different perspective from where we might be as Christians. There was one question: how do you summarize this quickly if you're faced with perhaps a patient and someone says, well, why are you being difficult here? How do you summarize that, and how do you start to perhaps have deeper conversations about your reason for behaving in a different way from some of your colleagues?
Yeah, I mean, I would say my 30-second elevator pitch goes something like this: people matter too much for me to be allowed to end them. That's basically the issue. And when we say that it's good to end somebody, we're forgetting how much they matter. So you can, and I would say you can't call into question the value of someone's existence, which is what you're doing when you're euthanizing them, without calling into question the value of the person themselves. You're basically saying, if you're willing to end someone, that they no longer matter, that they no longer have value. And that forgets the fact that they have intrinsic and unchanging and incalculable value, which we all recognize to be true. People are priceless and irreplaceable. So I won't participate in this, not because I don't care about human value, but because I see how deeply they matter. And so I think the effort there is to try and flip the tables and to show people that when they're supporting this, they're actually undermining human value rather than promoting it. So that would be my kind of 30-second elevator pitch.
Yeah, thank you very much. On a linked topic, obviously some of the cases that have been used in the media to make the case for the change in law here in Britain have been focused very heavily on suffering, and often with very emotional stories of how people are struggling with illnesses they have. You talked a bit about a Christian view of suffering, and someone put a question in the Q&A: what is a Christian view of suffering? How does that differ? Particularly if you're talking about perhaps the value of suffering, that is a very alien concept to many in our society. How do you talk about that, the value of suffering?
Mm-hmm. I mean, to be honest with you, I don't think that we can talk about that issue without appealing to the gospel, because this is why the death, the life, death, and resurrection of Jesus Christ matters, because otherwise we would have no hope in suffering. The human condition would be fundamentally tragic. And I think that one of the reasons why people find this so appealing now is because they literally live without hope and meaning. And so as soon as they have to suffer, just what is the point of this? And so I think it would be dishonest to try and respond in any way other than to say, honestly, you need to know that the God who made you loves you and was willing to give his son to die for you. Now, of course, in the clinic where we're having a professional interaction with patients, we want to be very careful about, the power dynamic that we have with patients, and perhaps we can refer them to spiritual care providers whom we trust to think through these issues. But I think that as physicians, we do need to be prepared to talk about problems of meaning and value, and to suggest that there are answers to these questions, and that, and in fact, your refusal to cause their death, to participate in their death, is a way of reminding them that they matter. The tragedy is that these people come into our care, they're frail, they're vulnerable, they're weak. And now we have a profession that, instead of standing as a bulwark against their own vulnerability, sort of leverages their vulnerability to end them. And that's, as I think, part of the problem here is the deep loss of the dignity of the profession, because it's forgetting the value of the patient who's in their care. And so our task as physicians to remind people that they matter by refusing to participate, and by, directing them in ways that can help them to think about meaning and purpose and value. And of course, to be honest with you, palliative care colleagues are very skilled at this already. I mean, this is the kind of work that they do. And I'm sure a palliative care physician, maybe in the audience or could speak to this, quite powerfully. Most of my patients are incapacitated in the ICU, so I have perhaps less experience with those kinds of conversations, but in the clinical setting. But ultimately, I think the truth is that the gospel is the answer to this problem of meaning. And so we need to be honest and forthright. And for a kind of a more full-fledged kind of Christian vision of suffering, I'd invite the person who asked the question to read my book, How Should We Then Die? Because I have a whole chapter focused on that issue.
Thank you, Ewan. We've had a couple of questions about hospices and palliative care. Perhaps you could just give us maybe some examples or some how that's played out in your institution. Have your palliative care colleagues been the most affected doctors by the change in law, change of medical practice?
Yeah, very sadly, I think that one of the things that immediately happens is that in the mind of the public, palliative care becomes linked with euthanasia, because they think, oh, okay, these are all doctors who are dealing with death. And the palliative care community in Canada made a very concerted effort to try and keep them separate professionally. So there are certainly palliative care physicians who participate in euthanasia, but there are many who won't. And we can only hope that as this practice becomes more accepted over time, that the palliative care community kind of sustains their resistance to being linked to this. But most hospices in Canada will allow patients to be euthanized. In fact, there are hospices that have refused to allow euthanasia, that have been shut down by the government because they're not providing, quote unquote, all medical care. So it remains an area of significant controversy and conflict. But unfortunately, many patients will have a hard time finding a palliative care environment where they can be confident that this won't be practiced.
Yeah. Okay. Thank you. I'm going to give you just one more question. Thank you so much for everything you've shared. This one comes from someone called Fronica. I'm not sure where they're writing from, but they say, MAiD is coming towards us like a tsunami. The number of patients waiting for MAiD is increasing every day. How can we best pray about this?
Well, I didn't mention prayer in my presentation, but I think that's a very apt response, to be honest with you, because increasingly it's become so clear that there are spiritual forces at work behind this that are far more powerful than mere humans can respond to. This is there's spiritual warfare going on. You see that in Canada and the way that it's being progressively expanded, and now there's a lot of talk about mentally ill people being made eligible for death, and it just seems to say an inexorable push to grow the pool of people for whom death is the only answer. And so absolutely we need to pray, and I would encourage everyone to pray that the Lord would sustain physicians and other healthcare practitioners and their opposition to this practice. Secondly, that the Lord would grant wisdom to those who are in government to rule and govern well and to protect freedom of conscience, along with protecting the sanctity of life. And that in jurisdictions where this is being promoted, that the Lord would turn the heart of the king, so to speak, the government and the public against it, so that people would be reminded again of the value of creatures made in God's image. And finally, to pray for revival, because ultimately I believe it's when people understand and believe the gospel that they'll see just how much we all matter in God's sight, and something like this will just no longer make sense to people. So lots of ways to pray, and that's really a great question. Thank you.
Well, thank you very much, Ewan. I don't know if you can see it, but across the screen, there's lots of clapping hands and hearts floating up at various points through what you've been saying. So I think that's been much appreciated by all of us. I certainly feel I've learned a lot from that. So thank you so much for contributing. And I think you're at the beginning of your day's work over in Canada. So all the best for what comes ahead today. Thank you very much to everyone who's joined us and those who are watching this recording subsequently. Thank you again, Ewan, for your time. Thanks everyone for listening. I'm going to close it there. God bless you all. Thank you.